The software that I use is TraumaCad. There are other software platforms available, but this is the one that I'm most familiar with. This is a patient of mine who's presented with lateral knee pain on both the left and right side. And for the purposes of this video, we're going to be focusing on the right side. So this long leg alignment view has been taken and it looks to be have been done very well. We look to see where the images have been stitched together, and you can see that there's no step along the bones. The calibration marker is at the level of interest, which is around the knee joint, and the patella are in the center of the knee. So we have to then identify the view we're looking at, and in this case we're looking at an AP view, and we're going to be looking at the right side. The software has automatically picked up the calibration marker, and we just scroll in by using the center of your mouse to the calibration ball to make sure that we are happy with the automatic detection, and in this case I am. You can adjust the metal ball size depending on what's within your department, but in our department the metal ball size measures 25.4. So I'm going to accept that, and I'm going to zoom back out again, and it's easy to do by just clicking on fit to screen, and you can see the whole image in one go. So go over to the top left and click on unilateral for limb alignment analysis for this instance, since we're only looking at the right side, and then the wizard will tell you where to put your markers. So I roughly do this as I go along, and then I go back and adjust them according to where I would like them to be. So I just use my mouse again to scroll into the femoral head, and I put these markers at 3 different places around the femoral head, which allows the software to work out the center of the femoral head. And you can see this circle now goes all the way around the femoral head. I then zoom out again and focus in on the knee joint. You can see my markers are roughly placed. I take the tibial one out the way and mark out the lateral distal femoral joint line. And I do this by marking out the most distal element of the femoral joint line. And I do the same for the tibia. And you can see that because this patient has got quite severe lateral disease, actually the lines come into contact with each other, which is not unusual. I then zoom back out again and focus in on the ankle joint and mark out the center of the ankle. Now you can either use the soft tissue envelope or the talus or the ankle joint. I prefer to use the talus, and this is now defined the center of my femur, center of my center of the hip joint, center of the knee joint, and center of the ankle joint. I then go over to the top left-hand corner to see where the deformity is arising from. So you can see that it's only the lateral distal femoral angle, which is slightly abnormal, and the mechanical axis is going through the lateral compartment. So in order to correct this patient to either neutral or slight varus, we need to do an osteotomy in the femur. My preferred osteotomy in the femur is a closing wedge osteotomy, and to get this patient into neutral or varus alignment, we need to do a medial closing wedge osteotomy on the femur. So we zoom back out again, and we show the computer where we would like to make the osteotomy cut. So firstly, we identify the femur, and once I've done that, I click on closing wedge so that my hinge point will be closing when I do the osteotomy. I get rid of the Cora lines. I don't need them for this instance. I zoom back in again. Now, the hinge point for my osteotomy needs to be above the lateral femoral condyle, and you can see here I'm just placing that approximately 5 to 7 millimeters away from the lateral cortex. And then the starting point of my osteotomy is above the flare of the medial femoral condyle, allowing enough room for the plate to sit for when I do my closing wedge osteotomy and in good metaphyseal bone. The next thing I mark out is the point to which I wish to perform the correction to. So in a valgus alignment, depending on the literature that you read, you can either correct to 50% of the width of the tibial plateau or 45%. So let's click on the ruler, work out what the width of the tibial plateau is. And in this instance, is 76.4 millimeters. And we are going to now measure what 45% of the width of the plateau will be, with 0 being the medial side and 100 being the lateral side. So I put that into my calculator and I come up with a figure of 34.38. So I use my ruler again from the medial side and I measure up to approximately 34 millimeters. Okay, so it's 30. So we calculated 34.38. This has come to 34.4 millimeters. Excellent. So now we're in a position where we know where we want to correct to. We've marked out where our osteotomy is going to happen, and we have an idea of where we would like to correct to. So we go ahead and click on the Finish and Cut button. And this defines the distal and proximal fragments, with the hinge point being where we defined it to be. And now we can click on the distal fragment. And when we do that, we can hover over this yellow circle. And once we click and drag, we can move the osteotomy in the direction that we want to. Now, as I gradually head to keep an eye on the mechanical axis to see where it goes to the point where I wish it to correct. So we're just missing that at the moment. So you have to take your time and get to the point you wish to get to. So that looks good there. So in order to correct this patient to 45% of the tibial plateau, this patient requires a small osteotomy of 4.4 millimeters, and that's a medial closing wedge distal femoral osteotomy. I then have a look across to see what that's done to my LDFA, and you can see that's gone to 88 degrees, which is within the normal limits. So when we zoom back out again, the alignment looks good, and I know that I haven't created a secondary deformity. And to finish off, I can simply make a report and note to correct to 45%. This patient requires a medial closing wedge distal femoral osteotomy of 4.4 millimeters. I can then save this case onto the cloud, and this is now accessible wherever I perform the surgery, as I have my own Quentry account, and I click OK, and this gets transferred across to the cloud. So this is how I perform planning for a distal femoral osteotomy. So now we're going to do a demonstration of how we plan a high tibial osteotomy for a patient presenting with varus. The first thing to do is to make sure that your image is of appropriate quality. So on this film, I can see that the seams are done away from the area of interest, which is around the proximal tibia. There is a calibration marker around the proximal tibia, and there's a ruler going down the middle. The patella is centered on both knees, and in this instance, this patient's got right medial knee pain with MRI evidence of wear on the inner aspect of the knee. So we're going to go ahead and plan a osteotomy for this patient. So firstly, we need to select the views. So we're doing an AP view. We're looking at the right side. The calibration can either pick this calibration marker up automatically, or you need to manually define it. In this instance, we're going to manually define it. So I can show you how to do that. So click on manual and click on circle. The circle calibration ball is typically 25.4 millimeters. Now, using the central scroller on your mouse, just click in the area around the calibration ball and put 3 markers around the ball till you're happy that you have got an accurate measurement. Okay, once you're happy with that, you can accept the calibration. Okay, so now we've calibrated our image. You can go to this fit to screen to go back out and go to the limb alignment analysis and click on the unilateral buttons. This was just planning the right side, and the wizard will show you where to put the markers. Now I put these markers roughly where they need to be according to this image on the left, and then I will go back in and put them, place them more accurately. So let's go up to the hip joint. Now the most important part of this is to put the markers around the femoral head, and this will help you to find the center of the femoral head. And I'm pretty happy with that, the center of the hip there. We're then going to go down to the knee joint itself, and so we mark out the distal femoral joint line angle. So the lateral distal femoral angle is then given to us, and you can see up here the LDFA. And once I'm happy that I'm across the femur is 87, and I do the same with the tibia, put it exactly where the width of the plateau is, in line with the joint line, and you can see I've got a reduced MPTA. And so for this patient who's got various alignments, it's suitable to go ahead and plan in the tibia. So I'm going to go down to the ankle joint as well, make sure that we're at the center of the ankle. As I've discussed in my presentation, you can either use a soft tissue envelope or the bony envelope. I tend to go for the center of the talus, and I'm very happy with that position. Okay, so now that I've defined my LDFA and my MPTA, and I've recognized that the MPTA is reduced, I'm happy that I can go ahead and do a tibial osteotomy. So I then define markers on the tibia, the central line, and the proximal tibial joint line. I get rid of the Cora lines because I'm not going to be using those for now. And then I zoom back in and place my hinge where I think it should be. So you can see here, by using the scroller to zoom in and out of the picture is pretty easy. So this is the top of the fibula head, approximately 5 to 7 millimeters. So let's go for 5 to 7 millimeters from the edge of the lateral cortex. So that's going to be my hinge point. And I've left enough room on the medial side for my plate to fit and to stay in as close to metaphyseal bone as possible, so that I've got a good healing bone. And that's where my osteotomy cut's going to be. This circle here represents the hinge point. Now I need to then be able to identify the point to which I want my mechanical axis to go to. The way I do that is I mark out the width of the tibial plateau. And in this instance, it gives me a measurement of 78.6. And I then put 78.6 into my calculator and multiply that by 0.055, because then this will then give me the point at which the value that I want to correct the mechanical axis to is 55% of the width of the tibial plateau. Traditionally, we've used the lateral tibial spine or Fujisawa's point, which is a bit further, around 66%, but 0.55 of 78.6 is 43.23. So we'll go roughly in that area of where we want to end up. You can zoom in and out and get it as accurate as you wish to be. We try to be as accurate as we can. So 43.3 is good. Excellent. So now we're in a position to execute the osteotomy. We know we want to correct the mechanical alignment. You can see this line here is going through the medial plateau, and we want the mechanical axis to go to the mark that we've made here at 43.3, which is 55% across the width of the tibial plateau. I click on Finish and Cut, and the software then defines the proximal and distal fragments. Now you click on the distal fragment in order to make that distal fragment move. And there's a circle here. And this circle, you have to move left or right, depending on whether you're opening or closing, and it will pivot around this hinge point. So if I do that now, you can see I'm now pivoting at the hinge point, and I'm also keeping a close eye on my MPTA, and I can see that once I get to the point where I want to correct to, I'm now at 90 degrees of the MPTA. And at the same time, this has nicely calculated the amount of opening that I wish to perform. So to correct this patient's varus alignment, I need to correct to I need to do a medial opening wedge high tibial osteotomy of 10.3 millimeters. Now, depending on the saw blade that you use, in my practice, I use a saw blade which is 1.2 millimeters thick. You need to be able to add the 1.2 millimeters onto the 10.3, and this gives us a nice round figure of 11.5 millimeters opening on the medial side, and all our parameters are within normal limits, and we've corrected to 55%. So I'm very happy with this plan. I'm not creating any secondary deformities, and once you are happy, you can just make a comment as to the degree of correction that you like. So this patient requires a medial opening wedge high tibial osteotomy of 10.3 millimeters. So I can just make a note of that, and once you're happy, you can save the case.